So,
Yes, sir.
so we just discussed ना कि हर एक autoimmune को तुम type of hypersensitivity and mechanism of disease में classify करो, तो treatment अपने आप तुमको आ जाएगा.
Yes, sir.
हर बार वो अलग बाय हार्ट करने की जरूरत नहीं पड़ेगी. थोड़ा subtleties हर एक चीज में होता है, वो पढ़ सकते हैं, of
Yes,
course.
Hmm.
Then in terms of the monoclonal antibodies also that we use, na, we can classify them into those which act mainly against type 2 and those which act against the type 4. The anti-CD20, so the CD number of the monoclonal antibody will often give you the clue कि ये कहाँ पे काम करेगा. बराबर. कि this is another thing which sometimes we may struggle to remember and by heart, na?
Yes, sir.
So like rituximab is anti-CD20. Now CD20 is mainly for B cells, and B cells are the ones which create the antibodies.
Antibodies.
Huh?
Right.
So antibody-mediated diseases में rituximab will be a common answer.
Yes, sir.
Same thing. Adalimumab is, I think, some anti-CD3, CD4 something. I'm not sure. Adalimumab is anti-TNF. Okay.
Yes,
Then
sir.
there is one more, I think, Natalie या तो ऐसा कुछ which is anti-CD4.
Infliximab etanercept है. Infliximab etanercept.
हाँ, anti-CD4 antibody कौन सा है?
CD4.
चेक करो.
Anti-CD4 monoclonal.
नहीं है ऐसा कुछ.
नहीं सर.
Natalizumab देखो क्या है.
The CD4 monoclonal antibody caliximab करके.
Okay, Natalizumab क्या है देखो.
Sir, it is an anti-integrin antibody, monoclonal anti-integrin antibody against against alpha 4 subunits of integrins, which prevents the migration of immune cells.
पता नहीं फिर. I can't remember. There are some which are anti-T also, antibodies. तुमको मिला तो देखो.
Yes, sir.
हाँ? There are some more well-known ones also. फिर वो so now IBD, हाँ, inflammatory bowel disease.
Yes, sir.
तो उसमें से Crohn's है, that is purely type 4 hypersensitivity. Granulomas वगैरह सब आते हैं उसमें. तो उसका भी treatment will be along similar lines to rheumatoid arthritis and all this.
Yes, sir.
ठीक. So ऐसे correlate करते जाओ, फायदा होएगा. ठीक है. Then patient का क्या हुआ आगे बोलो.
The patient had a history of intermittent hemoptysis during the previous 5 years and reported no recent headache, changes in vision, malaise, fatigue, chest or abdominal pain or diarrhea. He had hypertension, atrial fibrillation, for which he had declined anticoagulation therapy. Hepatic and renal cysts were present. He had benign prostatic hyperplasia and an aneurysm 4.3 by 4.4 centimeters of ascending thoracic aorta as revealed by CT imaging 2 years earlier. He had orthopedic surgery, an appendectomy and deep vein thrombosis, which was then treated with heparin. He is married, has children, and has retired from the construction industry. He was a current cigarette smoker, 55 pack years, drank alcohol occasionally, and did not use any illicit drugs. His
हाँ
father died at the age of 58 years due to myocardial infarction, and his mother died at the age of 67 years because of breast cancer.
ये सब
It's a family
नहीं ये
history.
सब टाइम
Yes.
पास है, पर मैं आगे क्या बोला है उन्होंने, मेन चीज बोला.
So on examination, his blood pressure was 135/85, pulse was 85 beats per minute. This is when he presented to the hospital, to this hospital.
मेन पॉजिटिव फाइंडिंग्स बोलो.
Yes, sir. He had faint crackles in both lungs, normal
हम्म
SpO2 and normal respiratory rate, 3 plus fitting edema up to the knees, and a non-palpable pink blanching macular rash on both medial malleoli. The remainder of
हम्म
examination was normal. All
हम्म
the other tests were normal. A chest radiograph revealed focal patchy opacification in the right lower lobe. And diagnostic tests were received and management decisions were made. So, in differential diagnosis, they have mentioned that one is RPGN, progressive glomerulonephritis. Second, they have
या
mentioned is a good Pasteur's syndrome. Third
या
is quasi-immune glomerulonephritis.
हम्म
And fourth is immune complex glomerulonephritis.
हम्म
So in a patient with RPGN, the finding of red cell casts will allow for a clinical classification of progressive glomerulonephritis. So
हम्म
इनका किडनी बायोप्सी किया था, इस पे लिखा हुआ है. So they directly did a renal biopsy because this patient had rapidly
यस
progressive glomerulonephritis.
यस
Directly did a kidney biopsy which confirmed crescentic glomerulonephritis. And its differential diagnosis included ANCA-associated vasculitis, anti-GBM antibody disease, lupus nephritis, post-streptococcal glomerulonephritis, Henoch-Schönlein purpura, and IgA nephropathy. The patient's history of one episode of hemoptysis suggested good Pasteur syndrome, while the vomiting suggested of HSP and gastrointestinal involvement. On examination, the rash on his legs was not palpable. So no palpable purpura will rule out the HSP. However, he said that with certainty that if he had run his hand over the rash with his eyes closed 1 or 2 weeks ago, he had felt a texture to it. They awaited the serological test results, and microscopic examination of the urine sample revealed proteinuria, hematuria, and numerous granular casts. The patient had already received glucocorticoids to halt the kidney function decline, and the more immediate concern that first involved controlling his hypertension, especially given his enlarged abdominal aortic aneurysm.
एन्यूरिज्म. हाँ
Yes, sir. So his kidney biopsy revealed on light microscopic examination revealed glomeruli with numerous cellular and fibrocellular crescents in the urine within the urinary space. The underlying glomeruli had a proliferative appearance with occasional formation of well-defined mesangial nodules. Some glomeruli had a loss of mesangial cell nuclei and lacy disrupted appearance of mesangial matrix known as mesangiolysis. The other glomeruli showed segmental or global sclerosis and adhesions to the Bowman's capsule. The GBM was focally duplicated with periodic acid shift staining. Yes. And chronic changes were also identified in the tubulo-interstitial compartment with interstitial fibrosis and tubular atrophy. So renal tubules showed mild acute injury and with epithelial cell vacuolization and regenerative changes. The immunofluorescence study done on this patient revealed IgG in a linear pattern along the GBM. Fibrin was seen within the cellular crescents. IgM and C3 were seen in segmentally scattered glomeruli. The electron microscopy revealed widespread effacement of podocyte food processes. and there were focal subendothelial electron-lucent material depositions in the endothelial cells.
ये लाइन लीनियर में अपना काम हो गया, बाकी
Yes, sir.
सबसे कुछ मतलब नहीं। आगे। हाँ। Anything significant?
So the patient was then confirmed to have a anti-GBM disease and was treated with
Yes.
glucocorticoids, cyclophosphamide, and plasmapheresis. And aggressive treatment led to better patient survival, reaching 85%. Plasma exchanges continued. Okay, what to do? So they continued plasma glucocorticoid therapy. They used plasmapheresis to remove the anti-GBM antibody and started him on cyclophosphamide. The patient underwent his aneurysm repair on the 10th hospital day because of concern about rupture of aneurysm. At the time of discharge, on the 21st day, he had undetectable levels of anti-GBM antibodies in his serum. And his creatinine was 3 milligrams, 3 mg per dl. He presented 2 weeks later with progressive kidney failure, which required hemodialysis. And a month after that, a perforated viscus developed, and it was noticed, and it was decided that surgical repair was not within his goals of care, and he died soon thereafter.
अच्छा, okay.
Glomerulonephritis. उनको सब तीनों ड्रग्स दिए थे, लाइक स्टेरॉइड्स भी दिए फॉर टाइप 1, और उसको टाइप 2 के लिए फिर उसको प्लाज्माफेरेसिस भी किया, और टाइप 3 के लिए उसको साइक्लोफॉस्फेमाइड भी दिया। टाइप 3 remains.
Hey, so see, steroids will work on all types. Steroids are pan immunosuppressing. उससे सब चीज सप्रेस होएगा. Cyclophosphamide, I don't know exactly, but उसका भी थोड़ा बहुत broad ही है. You can use it in many places.
Okay.
This is just to orient your this thing. इसमें एकदम ऐसा 100% ऐसा नहीं है कुछ भी.
Yes.
I'm just giving you a broad idea.
Yes.
So I think we can stop here.
Yes, sir.
इसका मुझे recording का link भेज दो. हाँ?
Yes, sir.
तो कैसे भेजेंगे?
Sir, actually, इसका recording is on my laptop, the first one. So can I send sir a Telegram के through भेजू sir?
Telegram से.
Because बड़ा
Or
file.
you can send email. Email भेजना तो email भेज दो.
Email पे. Okay, sir.
हाँ या Telegram पे. I'm there
Yes.
on Telegram.
Okay, sir.
Okay. Yeah.
Thank you, sir.
Okay, sir. Thank you.
Bye, sir.
तो एक मैं आपको एक ये अच्छा एक्सप्लेन किया हुआ एक लेक्चर में वो भेजता हूँ, मिलाता हूँ. हाँ?
Yes, sir.
अच्छा.
Yes, sir.
Okay.
Thank you, sir.